Okay, so that's part three of the series. So we're going to continue going over some of the common views and measurements. So we're still in the apical view, and this time we're looking at one of the marker of like high RV and diastolic pressure, or right like when you have like some degree of diastolic restriction to your RV or pulmonary hypertension or TR, things like that, your RA will start to become loaded. And so one of the way to attempt to quantify this is to get the maximal atrial planimetry of the right atrium. I'll be fully honest, it's more a marker that we use in research, especially because we do a lot of research on pulmonary hypertension. Because with pulmonary hypertension, if your RV is facing a high afterload, your RV starts remodeling, initially becomes dilated, and eventually starts to hypertrophy. And then based on this, you start having a lot of decrease of compliance of your right ventricle, and the pressure will start to rise in diastole. And because of that, your right atrium may not have an opportunity to completely offload itself at tricuspid valve opening, especially if there's no ASD to kind of offload to another degree, or if the LA pressure increased as well. And so the RA might not be able to completely empty itself, and you can start to get some degree of RA dilatation. So that's one of the marker we'll measure, for example, in research. And typically what we do is that we go to the peak of systole. So when the RV is completely contracted and the tricuspid valve is closed, that's when the RA is fully filled, right? Because during ventricular systole, the right atrium continues to get filling from the IVC and SVC and coronary sinus. These are kind of the three sources it gets typically the blood flow, plus or minus an interatrial shunt if there is one. And eventually in diastole, typically that's when the RA, empties into your ventricle. And so that's where we would measure the planimetry, which is an area, so it's not a volume. The American Society of Echo has recommendation about how to get dimensions of your right ventricle. So if you're worried about right ventricular dilatation, typically you'll measure some of the diameters in different views. One of the views is in the apical view. So we try to get what we call an apical RV focused, which means that you want to see the myocardium and the endocardium of your RV. You want to see clearly your tricuspid valve, and you want to see your right atrium. And you want to be able to see kind of the apex of that right ventricle, which has a bit of that triangular shape, as you can see. And the length is typically from, the tricuspid valve to the apex as the longest measurement in diastole, so at the peak of filling. And then your diameters are number one, what we call the base, which is the zone on which the tricuspid valve sits. And then what we call the mid cavity diameter, which is typically you go halfway and you take diameter. Just a second. Sorry for this little stop. So that's an example of number one, your base, number two, your mid cavity diameter, and number three, kind of the length, which goes parallel to your septum from the mid zone of your base, usually to the apex. So you can also get your RV length in systole to compare kind of the systole diastole, and that's something we would do sometimes in research. It's rarely done in the context of just clinical measurements. And some of these normative dimensions have been published. So we're able to go to some of these references, which are also referenced on the website. So this is parameter Z, for example, which is the Ratty Children calculator. There's also the Boston calculator, the Pediatric Heart Network, and they have some of these normative values for the kids to see, do I have signs that my RV is dilated? So similarly to the RV, you can also get some information about left atrial size. Your left atrium is obviously influenced by various factors. Number one, it's influenced by the pulmonary blood flow. So if you have, an adverse pulmonary vasculature and you're not able to fill your pulmonary vasculature and you get limited amount of pulmonary venous return, your LA will be underfilled. That's number one. Number two, if you have venous dilatation, you get a lot of pooling everywhere in your body, and so less blood flow comes back to your RA, and eventually less blood flow goes through the lungs and less blood flow comes back to the LA. And that's true also for patients who are underfilled intravascularly. So think about situation like capillary leak, bleeding, acute hemorrhage, so severe IVH, pulmonary hemorrhages, intra-abdominal hemorrhages, situation where you may have hydrops and you may leak into certain cavities and lose a lot of intravascular volume, lymphatic disorders. So there's many reasons why babies could be underfilled: acute event, cord events, placental abruption, fetal maternal hemorrhages, things like this. So there's pulmonary venous return that will affect the LE size. There's obviously your interatrial shunt. So for example, if you have a really large hemodynamically significant PDA with very high QPQS and very high pulmonary blood flow, a lot of systemic seal, well, you get tons of pulmonary venous return, and eventually this LA at some point will start to become a balloon and get really much filled. But if you do have at this level an interatrial shunt, you may be either popping off a lot to the right atrium. So that's one thing. Or number two, think about patients who may have mitral valve restriction, mitral stenosis, mitral regurgitation, poor LV compliance, LV hypertrophy. Then this LA may not be able to kind of empty out. So that's always something you have to keep in mind when you're looking at these patients. Like if you have a big LA or a small LA and it doesn't fit the physiology that you're kind of in your mind, oh, there's a big PDA, I'm supposed to have a big LA. Why am I not having a big LA? Well, could it be that the QPQS is not that high in the end? And maybe I have a lot of pulmonary vascular resistance issues. Maybe I have a massive ASD and it's just flooding the RA and the RV instead. Maybe my LV is very compliant and I'm able to like balloon out my LV. Okay. So sometimes I say, like, for example, patients who will undergo some courses of steroids, and we know steroids makes them at risk of developing ventricular hypertrophy. And often one of the questions we get is there significant LV hypertrophy? Of course, when you have large PDAs with a lot of left atrial preload, which eventually fills up your LV and makes your LV super well preloaded, maybe it's going to thin out these, LV cavity, and whatever hypertrophy there was, you may not see it as well just because you have so much preload versus a kid, same amount of steroids, same amount of hypertrophy inherent to the myocardium, but then you remove that PDA and you kind of remove that preload to the LE and LV, maybe that actual hypertrophy will become much more apparent. So sometimes in these patients where I have hypertrophy, I'm kind of, I don't know what's worse or what's better, but I'm less concerned when I have this kind of PDA physiology that can help stent my left ventricle and like provide that degree of filling to the LV without leading to like LVOT obstruction because of the hypertrophy. So that's one thing, to keep in mind. The other thing, if you have poor LV compliance, if it becomes very, very stiff, then obviously when your mitral valve is going to open, the relaxation properties will be impaired and your LV and diastolic pressure may be higher and your LA may not be able to kind of empty out into the left ventricle as well, because just the LV EVP is higher. And so the atrial mechanics are highly dependent on the underlying ventricular kind of compliance. So your shunting directionality, for example, at the ASD level is dependent on that. And if you have a restrictive ASD versus a large ASD, it may change how this LA volume is being assessed, right? So think about a very stiff left ventricle, not able to open, but there's like a massive ASD, that LA might just like empty out completely in that RA. So when I see example patients with prematurity, who's now they're much older, and they have some degree of high right ventricular pressures, and I see that I have a massive ASD that is left to right, and I see my PA pressure estimated to be abnormal, like / corresponding to some degree of pulmonary hypertension. At this age, it's very rare that an ASD shunt, because it's a volume shunt, will create pulmonary hypertension due to excessive volume. But we know that our preemies are different than term babies. They have more stiff left ventricles, they have smaller left ventricles, they have fibrosis, all these reasons why the LV properties may not be relaxing as well. Some of them are hypertensive, they had acute kidney injury, they have high systemic vascular resistances. Think about the kids who are born from a growth restrictive setup or placental deficiency, insufficiency. They may have like a lot of SVR issue, and because of that, it kind of goes back to the LV, which becomes stiffer. And these patients, because they have a stiff LV, it kind of promotes much more blood flow from the LA to the RA than what would happen usually in like a term baby, which has transitioned nicely and has an equivalent size ASD. So some of these patients may actually show more signs of raised PA pressure during the actual neonatal life once they get term corrected and they have a big ASD just by this mechanism of poor LV compliance. And often with diuretics, at least, there's no randomized control, but at least clinically we see that their RV pressure on echo goes down. So that's one thing to kind of consider when you have these patients with big left to right shunt at the ASD level. But just to say that one of the things, of course, you can measure the LA diameter in the short axis on M mode, on the long axis on M mode. But more and more, what we're doing is we're tracing this left atrium and we get a left atrial volume. And this is done at the peak of contraction when the LA is supposed to be the maximally kind of filled. And you wanna basically go along the endocardial wall to really encompass the entire left atrium. And rarely you shouldn't really incorporate the appendage. Here we see a bit, or it might be a pulmonary vein that's coming to connect or something, but really you want to follow kind of until the hinge point of the mitral valve. So again, in a sense of offloading phenomenon, the LA volume will increase if there's significant left to right shunt by the PDA, if there's other etiology of significant pulmonary circulation, if there's a blockage, so if you see an obstacle like a mitral stenosis, or if you get a lot of regurgitation because the LV is emptying into the left atrium. And again, if you get like diastolic properties that are abnormal. I don't like the word. I've put diastolic dysfunction. I just don't think we know nowadays what is dysfunction or not in the newborn. It's very hard to tell. So then you can use your probe and rotate a bit and go more anteriorly in order to see better what we call the LV outflow tract or the 5-chamber view. Why 5? Because you get your RA, a bit of your RV kind of in the body / infundibulum portion. We're kind of almost there. You see the LA and the RV. This is not a perfect 5-chamber because I would have liked to see my mitral valve open and close as well. But here, what this particular clip wanted to show is that you have nice unobstructed flow and no acceleration through your aortic valve. Sometimes you can have trace AI. You see maybe a little blip of red here, very physiological in these patients. You don't want to miss any significant aortic insufficiency. Aortic insufficiency will make your LV preloaded during diastole. From the aorta to the LV. So you get kind of a steal. And if it's significant, you can even see retrograde flow in your arch because of that. And you get less kind of effective forward flow. So it kind of drops your cardiac output. We see sometimes aortic insufficiency in patients with, significant LV dilatation. So LV dilated cardiomyopathy, infant of lupic mothers with congenital heart block, severe LV dysfunction after asphyxia or coronary insults. And so obviously these patients, you want to check all these things like coronary and things like this and kind of promote LV function if the problem is LV inotropy, that's a problem. And you can use sometimes the Doppler of the aortic insufficiency because if you do the Doppler through it, like the continuous wave Doppler, you can get a sense of these, peak pressure during the retrograde flow into the LV. And that provides you with a sense of the gradient between the aorta and the LV. And so if you have like the value of your blood pressure at that time, you can take the diastolic blood pressure, remove your gradient, and you get a sense of that kind of LV and diastolic pressure. I mean, it's not super accurate, but you get a sense if it's highly elevated or with a normal limit, especially if you have a full curve. But what we use mostly this is to put the cursor at the level of the LVOT, typically just at the valve or just under the valve to get what we call the pulse wave Doppler in order to estimate stroke distance. So here you have your velocity in meters per second and you have time. You can see the QRS here. So as you get QRS, you get activation of your ventricle. Eventually your aortic valve will open and you get a nice tracing of ejection up to the closure of the aortic valve, which is here. And then if you trace the area under this curve, it's basically doing the average of all of this. So multiplying the velocity by a time provides you with a distance, and that's an estimation of what we call the stroke distance, which is instantaneous. It means that it's exactly at the point of the cursor. And what you want is that line of interrogation and the flow into this aorta to be almost parallel as much as possible. Here you see that, the cursor is like this and the flow is like this. So you have about 20 degrees in between. We tolerate up to 30 degrees, but ideally you want to have almost 0 degrees. So that's why, sometimes you have to tweak and adjust the angle that you're taking this. And so this is what we'll be using to estimate left ventricular output, which is quite important in our field to understand, if the LVO is high or LVO is low in the context of cardiac dysfunction. It's going to be a metric that we will be following as we're introducing therapies to improve cardiac output. So that's an example where, first of all, this patient, if I would, always look at my images to see, am I doing the kind of right imaging? So first of all, I'm a bit oblique, probably because the imaging was not ideal, very difficult windows. So you have to take this with a grain of salt in the sense that your angle of intonation, you have here the outflow track and you have here the angle. So maybe your angle is like 30 to 40 degrees, so it's slightly high. So it might underestimate, but clearly you see that the profile of this versus the profile just in meters per in terms of peak meters per second, it's very different. Here you get up to like 1.2, 1.4, and here you get like, that's 0.4, just to give you a sense. So that's 0.4 also. So that's very low. We see the peak gradient, the peak velocity is 0.36 meters per second versus here you get 1.4 meters per second. So you have very much smaller velocity. So this ventricle is not able to generate these high velocity, either because the contractility is not good or the afterload later is not good and it's blocking this flow, or a mix of both. If your SVR very high in the context of reactive poor output. So that's something important to take into account, but you can even see that the tracing, which represents the stroke distance, which is represented here, so it's 0.043 meters, is that stroke distance, is quite lower than what you would get in this particular velocity time interval. And so if you multiply by the heart rate, we call this the minute distance because it's normalized to time. So it's really a stroke distance times heart rate gives you a minute distance. And if you multiply it by a cross section of an outflow tract, you get what we call the output in cc per minute. And typically in newborns, we'll normalize this output to the weight of the patient. So we'll divide by the weight at the time of the echo. So we'll talk into cc per kilo per minute or ml per kilo per minute. And you can do this in the LV or the RV. There are some caveats that we don't take into account, such as like viscosity and things like this, but they may also influence a bit this calculation because they're all based on the Doppler shift effect, and sometimes they can change a bit with the viscosity of the blood. So again, cardiac output is stroke volume times heart rate, which is the VTI times the cross-sectional area times heart rate, and often indexed to body surface area. We say the normal values is about 150 to 400. I typically see more like 100 to 300, I'll be honest with you. When I get to the 300 to 400, it's often because there's like a PDA physiology with tons of blood flow coming back to my LV. And because of that and the Frank-Starling curve, you get much more contractility, and these patients get more output secondary to that. Of course, the limitation, you get increased error margin based on the LVOT measurement. I don't know if you remember, but I showed you that the LVOT measurement is highly dependent on the angle of where you're capturing this value. So you could see that depending on where you're capturing it, you might change a lot how your LVOT is being measured. And it also is not a circle. It almost like look like a flower. So we assume that it's like a perfect circle, but it's not a perfect circle, right? So these are assumptions that kind of bring variability and mistakes in the real calculation. And so you'll see sometimes numbers that, quote unquote, don't make sense because you have no shunts nowhere and you get an RVO of like 400 and an LVO of 250. I think what is important about is when you start getting these extremes of the individual value, because the moment you're going to be doing these calculations for the RV, the LV may not be at the same time. First of all, they may not be exactly under the same loading conditions. We know the RVOT is bigger than the LVOT in general in babies, so you may overestimate the cross-sectional area of these patients for the RVO. So you can't really use this as like a calculating exactly the QPQS. It just gives you a sense. And it's good to tracking your patient based on the therapy you provide to them. And it's very common we see, for example, in babies with HIE who are relatively stable hemodynamically, lactate is decreasing, the baby's peeing well perfused, cardiac function looks good on echo, you have normal ejection fraction or slightly depressed ejection fraction, but nothing that clinically would warrant kind of like intervention. But they'll have these borderlines, LVO, RVO, like 100, 110 cc per kilo per minute. And that's often also because their metabolic demand starts decreasing. So they just don't need that much blood flow because they adapt, right? So that's something to consider. They also have higher SVR, so their VTI might be a bit impeded by that because the velocities are generated at a less faster pace. So important to assess the output situation of poor cardiac contractility, abnormal excessive preload, underfilling, pulmonary hypertension, for example, LVOT obstruction, blood loss, if you suspect a patient that is very dehydrated. In dehydrated syndromes, you will see that this actual curve becomes much more, the systolic duration of your ejection is much shorter. So it's like you get like almost like a blip, boom, like this. Like it really goes back to your baseline very quickly because your LV are kissing and they're not able to eject that much, and the time they spent in effective ejection starts decreasing. So this is an example of your LVOT tracing. Here we try to align as perfectly as we can. You're at the level of the valve or just under the valve. You recognize that it's a pulse wave Doppler because of the two lines, and you trace your VTI, and you also trace your heart rate for that particular beat. So from the beginning of your ejection to the beginning of the next ejection, or you can actually measure from the beginning of the QRS to the next QRS, and it provides you a delta time, which in the new single version will automatically be translated into a heart rate. But if you don't know how to translate it, you do 60,000 divided by this number and it will give you the beats per minute. So basically, this is how long your beat lasts. And so one beat is 412 millisecond. So how many beats do I have in 1 second if this is the duration of my heartbeat? So that's the nice guidelines that were prepared by our community. It shows you how to trace the LVOT VTI, how to measure the actual outflow track, and how to plug all of this beautiful thing into the LVO calculation. If you go into the NeoCardiolab website and you go into the calculators, which are here, you will see that there is a nice calculator for cardiac output. Just make sure you have the right units, and then it will calculate it for you. And that's another example here of the calculator. So because you can do this for LVO, you can do this for RVO as well. So same thing, you want to be the best aligned. Sometimes, and most often, and actually most guidelines will use the parasternal long axis or short axis to be the best aligned in terms of the angle of inclination. So here you can see that I'm just below or near the RVOT, the valve. I measure my valve at the peak of systole when it's fully open at the RVOT level, so at the hinge point of the attachment of the pulmonary valve. And then here you can see there's a little trace pulmonary insufficiency here. And then you do your tracing of your Doppler VTI, and then you can measure your heart rate with the time, and then you can calculate your cardiac output in a similar fashion. Sometimes the best alignment you're going to get for the RVOT will be from the subcostal or apical view. So just to be aware that, although it's not the typical technique to be measuring this, if you don't get any chest view and your best alignment is from the subcostal, you probably want to go and obtain a view from the subcostal. Do you see my NeoCardiolab website? Yes, perfect. Let me see if I can do something here. September. Functional PV stenosis. This one is not published yet, so I just want to show you an example that I think I have here. I think I liked, yeah. So this is an example of the RVOT, the RV, so this is the RV outflow tract, this is the pulmonary valve, this is main pulmonary artery, and this is me trying to get my Doppler from the area just under the valve. You can see that the flow is going that way and my angle of inclination is like this. So I have a bit of a 30-degree angle, but in this particular patient, that was the best angulation I could get because of difficult views. The patient had like bandages on the chest. So the only view we had like was kind of the subcostal / the apical view. So let me reshare and go back here. When we have the outflow tracks, we often like to have also documented one continuous wave Doppler. So the continuous wave Doppler will be important if you're worried about any valvular stenosis. So that's one thing important for the RVOT or LVOT to see if there's a gradient, or there's valvular insufficiency to capture this in order to calculate the gradients. And then you have to keep in mind that, for example, if you have an RVOT that's doming, so a pulmonary valve that's doming, which means it doesn't open fully and nicely, you can have some degree of RVOT obstruction and pulmonary valve obstruction. And if there's a large PDA downstream to that, you will not have a gradient that is very high because your PDA is kind of sending pressure in your main pulmonary artery via the aorta. And so the gradient between that valve and what is happening in the MPA may be actually obscured by the fact that there's a duct that is still open. Okay, going back to my pulse wave Doppler, this is an example again in parasternal long axis where they show where to put the pulse wave Doppler, how the RVOT looks like, and the same calculation for this RVO. We use a 5-chamber view. This is a patient who has a particularly large left atrium. It's a kid who had, in this particular example, which is not the same as the view in color, but I can see here there's a large left atrium, and this was a patient with a particularly large hemodynamically significant view that was left or right, so flooding that LA, because the PVR are low compared to the SVR, there's steel effect, it floods the LA. And so what you could do is measure called something the isovolumetric relaxation time. So this IVRT is the time you spend relaxing, but your volume is technically not changing. So your mitral valve and aortic valve are closed and they're not leaking, okay? Which means that this measurement is typically obtained at the border between the red and the blue. So you see here LA, you even see a pulmonary venous flow that's kind of filling your LA. Your LA is filling through the mitral valve into the LV, swirling into the LV outflow tract and filling your aorta. So you get inflow directionality that's red in diastole and then blue in systole. And then you want to get your pulse wave Doppler exactly at the junction between this red and the blue. So it's the junction between the inflow outflow. It's something also they get in fetal life to calculate the what we call mechanical PR interval. You can read this on the NeoCardiolab website, fetal echo section on congenital heart block for the 2nd degree or 1st degree heart block. That's how they measure the PR interval in fetal life. But basically, on this view, what we see, we capture a bit of the systolic ejection, which ends here. And then you capture the beginning of your diastolic filling, so the early phase of filling, and eventually your atrial kick. So this zone, this actual little zone here, is what we call the isovolumetric relaxation time. And if your LA gets packed of blood flow, your mitral valve will open much quicker. So your IVRT will become much shorter. The other thing is that if you have aortic insufficiency, because let's say your LV starts dilating because of the LV preload, you get LV dilatation, the LV gets so much flooded that it's not able to eject everything in systole, so there's a lot of residual volume at the end of systole, and then your aortic valve will start to dilate and you get aortic insufficiency in these physiologies. And if you have significant AI or moderate AI, it means in diastole you're stealing, and so you don't get much of this IVRT because you already get volume filling retrograde into your LV during that time. So your IVRT period may start to become shorter and shorter because of that. So that's the example of how you would measure it. Okay, you can, I'm sorry, just a second. Okay. Then, so this is an example of how you can use these information to calculate something called the MPI, or the Myocardial Performance Index. We also call it the TI index, which is an index of systolic diastolic function. I'll be honest, it's something that is most often used in the cardio-oncology literature, adult literature on cardiomyopathy, and in the research literature, but clinically, personally, it's not something I use on a routine basis to actually quantify cardiac dysfunction. The interest about the MPI is that it includes both systolic and diastolic component of relaxation and contraction. So here, how you would measure your MPI is basically you want to include the calculation is you want to include the time you spend in isovolumetric contraction, this time you spend is isovolumetric relaxation, and all of this you want to divide it by the ejection time. Now, nowadays, it's mostly done using the TDI because you can get by tissue Doppler all of these information instantaneously with a very high temporal resolution. Before, people would use a pulse wave Doppler technique to measure it. So what we would do is that we would look at the actual ejection envelope of the LVO and measure the time you spend in ejection. So that was your ejection time. And then to measure your IVRT plus IRT, you would basically measure the whole time that you would spend between here and here, minus that ejection time or aortic flow. So it's a bit more complex to do using the two Dopplers. So this is something we personally have abandoned at our lab. So I'll go to tissue Doppler to explain the tissue Doppler. The tissue Doppler is basically the concept of looking at the velocity of a movement, but instead of looking the movement of the blood flow, we look at the movement of the tissue itself. And so it's a pulse wave Doppler, basically. So you do a pulse wave Doppler on the actual myocardial tissue. And by convention, most of the TDI imaging normative value have been done on the apical four-chamber view and looking at that longitudinal velocity motion, okay? It is dependent on the angle because it's a Doppler, right? So if your angle is more than 30 degrees like this, you're not going to capture the true velocity with your probes. Of course, you will change your velocity depending on the heart rate, depending on how much preload you have, afterload you have. So all these things can be, impacting these values. So the TDI looks at what? It looks at the motion in systole. It looks at the speed of the motion in systole. So because in four-chamber, if you see the four-chamber is here, your probe is at the apex. So the muscle comes towards the probe in systole and goes away from the probe during the relaxation and diastole. So you get a peak speed in systole, and then you get a peak speed in early phase of diastole, and then a peak speed in active phase of diastole or atrial kick. So basically, if you would see the speed, so your ventricle could move like this and then go back to baseline, or it could move like this and go back to baseline much quicker. The distance it has traveled is the same, but you just go faster in one versus the other. And that's what TDI informs you on. It's the speed of it, okay? So it's kind of a correlate to see the vigor of the ventricle. It is going to be heart rate dependent for sure. So you get systolic velocity, and then you get what we call the E prime on the A prime. What I find particularly interesting in the research aspect is with these stiffer ventricles, there's a ratio that's called the E on E prime. What is the E on E prime? It's basically so for the LV, it's that transmitral E flow. So we know the first wave is when the mitral valve opens and the LA is kind of passively emptying in this LV. So the idea is that if the LV is very compliant, so not stiff, when the mitral valve is going to open, you're going to get a huge gush of flow from your LA to your LV, and this velocity will be very high. So that's like the first concept. The second concept is that because your LV gets filled nicely, you get like a very rapid expansion of that myocardial wall. And this rapid expansion of the myocardial wall represents this E prime velocity. So there's a ratio that's called the E on E prime. And if this ratio is less than 12 in the adult literature and pediatric population, typically it means that the relaxation properties are very normal. But we don't have great normative value for babies. So that's one ratio that I find quite interesting, especially for research and diastolic properties of ventricles. The other thing that's going to be measured is this MPI ratio, which includes the isovolumetric contraction time, the isovolumetric relaxation time, and the ejection time. So it's a marker of a combination of systolic and diastolic properties of the myocardial wall. And so you can do this wherever you're obtaining a TDI, either it's the RV wall, free wall, the septum, which is typically kind of, given to the left ventricular cavity for this property of this particular metric, or the LV free wall, which sometimes is more difficult to obtain because you might be less aligned. And what you can do is you get, so this little flicker here is the motion of the wall during the isovolumetric relaxation time. This flicker is the motion of the wall during the isovolumetric relaxation time, so before you re-expand. So negative value, positive value is coming towards the probe, so this is systole. You remember red coming towards the probe systole, so positive value. And so if you take this entire measurement and you subtract B, which is only the time you spend in ejection, well, you end up with the value of this IVCT plus IVRT. So instead of doing 3 measurements, you just do A minus B divided by B, and you get this MPI. So that's an example. You have the IVCT, the IVRT, you have your ejection time. So you do B minus A divided by A, and you get this MPI metric. There's no particular number that is like, this is a normal MPI or this is an abnormal MPI. Typically like the 40 to 60 value, because you do this ratio, you multiply by 100 and it's like a percentage. So you get 40 to 60% of time that you spend in isovolumetric moments compared to your ejection moment. Typically it's kind of normal, but we see in newborns like 30 to 60 to 65%. It's really the extremes that start to become more concerning, and it's something you would follow. And it's not necessarily something I would use to kind of decide on, oh, I'm going to treat or not treat, but it's worthwhile to kind of follow for some of these patients with more concerning pictures. So other example, you get the IVCT, the IVRT in the middle, you get the ejection time. You can do this at the RV free wall. You can do this at the septum. You can do this at the LV free wall or lateral wall. And the idea is to really be at the zone on the myocardium that is just under the attachment of the valve, of the corresponding valve. So that's an example of at the septal level. So you see your S wave, your E, your A. This is an example at the LV free wall. So 2 examples that I've put here. And this is an example at the RV free wall. And the difficulty is obviously that if they have fast heart rate, this E on A may be also fused. So then it's, very difficult to actually isolate which wave is which. And then you cannot really rely on that to measure your E on E prime or things like this. Okay, I'll skip. There are normative value in the term and preterms. They're also like reference. So you can, you can go in normative value, and you can go into here, and so you'll have like the E to A prime for less than a year old. You can have also these one like children, neonates, so you have normative value here. This is for the preemies, less than 29 weeks. This is for the right ventricle for day 1, day 2. And then you also have cohorts that have been described by the Alkufash group in the Dublin Rotunda manual, where they provide also some normative value for term and premature babies. Okay. LV mass, I don't want to spend too much time because this is very research oriented. There's many methods. They rely on different algorithms. One of them is the areolar length method, which takes the value, basically the kind of area of that myocardium in the parasternal short axis at the mid-papillary level, and looks at the length in diastole and uses that to compute kind of a model of a mass. So you can do it on TomTec. Or you can do something called a truncated ellipsoid method, which also takes into account the diameter mid-cavity. Or you can use what we call the LV mass method by M-mode, which is highly discouraged by the American Society of Echo for various reasons that we described why the M-mode is not great. The DPDT, we spoke about it, Laurence, a few times. What is the DPDT? Extremely rarely obtained and of query value. But basically, if you have a TR jet or an MR jet, the speed at which you're able to generate that jet informs you on the vigor of this left ventricle or right ventricle in systole. So technically, a right ventricle or left ventricle that's able to contract very well will be able to generate very high speed of regurgitation if there's MR or TR. Of course, that's true if you only have a trivial or mild MR or trivial or mild TR. It's not something I would do in like a severe Epstein or significant MR because you have like necrosis of a papillary muscle or things like that. And so for the MR, you need your baby to have a certain degree of blood pressure to calculate that because your MR reflects your LV systolic pressure during systole. And so if your LV systolic pressure is like 25, you're not going to have enough velocity MR jet to calculate this metric. So what is this metric? It's basically looking at how much time it takes for the LV to be able to generate a speed from 1 meter per second to 3 meter per second. And so if this curve gets more stretched out, which goes with the idea that you spend more time in systole, then your dPdt becomes smaller. And normal values is basically your LV is able to generate more than 1,200 millimeters mercury per second. That's based on adult literature. When do I use dPdt, or when people use dPdt, not necessarily me, it's mostly in patient population where you have various like valvular insufficiencies, and it's more difficult to use the traditional metrics like ejection fraction and things like that to quantify. So in these patients, you're going to use things like the LVO. But if you have a lot of AI, then you don't know, is my LV load truly reflective of the true cardiac output? And then the other place where you may be using it is like hypoplastic left heart syndrome, for example, where you can use the RV dPdt to see how much this RV is contracting well. So that's an example of how you measure it. You go at 1 meter per second and you trace a line up to 3 meters per second, and it tells you how much time it took to generate that. And so you compute the MR of the dPdt. So here in calculators, I also believe I placed like a dPdt calculator if ever you would like to practice at some point. So that's an example with an MR. So you trace your 1 meter per second, you trace your 3 meters per second, and you do your kind of line in between. And then it gives you, this value is 10.56 meters millisecond. So if you plug it, it gives you 3,030 millimeters of mercury per second. And so you can put here T in 10.56, calculate dPdt, and it gives you this, and it tells you it's normal. Same thing for the RV if you have a TR. Now, RV are known to not generate similar amount of pressure than the LV. So we cannot use really the 1 to 3 because 3 is already like some degree of pulmonary hypertension in some of these patients that are a bit older. So the metric was validated between 1 to 2. And so you're supposed to be able to generate above 400 millimeters of mercury per second. So let's say I say here 10.56, you see that it like this would be very long. No, sorry, this would be okay. You would have 136, or you're more than 400. But let's say it took me 15, then you're 800. That's still fine. And if you're 18, well, you start dropping. And if I'm 40 millisecond, well, that starts to be kind of low. And so that's kind of a correlate of when we do the systolic to diastolic time ratio of the TR, because that's another marker. So if you measure the time you spend in systole compared to diastole, if the systole starts to impede on the diastole, it means your RV is struggling. So that's another way to see how the dPdt functions. That's another example. And that was the SD ratio that I was mentioning. And so that's true for an LV that you see here is quite dilated. That's not a very nice LV. It's an unhappy LV. And you see the systolic to diastolic time ratio becomes quite disfavored towards systole because your LV spends much more time trying to eject. Here I calculated for a TR. I had calculated again for a TR. And I'm not going to talk about flow propagation because that's a bit too much. And strain will be reviewed in another session. Okay, we are at subcostal view and it's 3:58 p.m. Been an hour. So tell me any questions. Okay, I'm going to stop the recording.